Hi, everybody. Welcome back to Ask AJ. I'm AJ Hanna from Sykes, and with me today is Anna Twomey of Blue Prism. Anna is a Senior Solutions Advisor for Healthcare in the Americas, and we've been partnering with Blue Prism for quite some time. I go back with Blue Prism quite a ways, but there's some interesting work being done right now in the health side, digital health for the enterprise, that Anna is one of the key drivers on in initiating and implementing, and has had some experience in healthcare leading up to Blue Prism. So I thought it would be an interesting conversation for us to have. Anna, thanks so much for joining me today.
Thank you, AJ. I appreciate it.
So let's get started. I think most people know who Blue Prism is, but if you want to say real quickly who Blue Prism is, and then if you don't mind, tell us a little bit about your path that led you into trying to automate in the healthcare space.
Okay. Thank you. And Blue Prism is robotic process automation at its best for the enterprise. It's built on a foundation for enterprise-wide deployment and scalability, security. It was born in the financial realm, and so therefore it's considered the most secure RPA platform in the industry. And I found out about robotic process automation after I had spent a lifetime in healthcare and a lot of technologies. My master's is in IT, but I had focused my entire career on healthcare. And so I've worked with a lot of different technologies in healthcare, a lot of different companies, working for states, local governments as part of I started initially with Novation and Foundation Health Federal Services, which were both in the federal space, right? The supply chain aspect of it, as well as the Champus and insurance capabilities. And then again, I went to the city of Houston as bioterrorism administration manager for the city of Houston. So for 4 years there, we were doing preparedness, similar to what we just came through with COVID and everything, but trying to prepare for something like that, like a pandemic. And that's when I started realizing so many problems that existed in healthcare and the way they exchange data, and how could we even check an infectious disease symptoms, rapidly, or be able to obtain information about it. So I worked with CDC for a couple of years, building out bioterrorism databases, and health information exchanges essentially is what came out of that. The health information exchange era, where we were building huge databases that would capture information on a person's patient journey, essentially what we'll be talking about today. But it was their patient journey from birth to death type scenario, and capturing all of that information and being able to exchange that regardless of wherever you are. If you go to Florida for the summertime or for the wintertime, and then you come back for the summer up to the northern states, where's your health care? Where's your records? Where is all that stuff kept? So that's where the health information exchange came into play. But in all of that movement, and in working for all those years, it's been about 25 years total that I worked in different areas of technology for healthcare. I had never seen anything that would allow us to really start making a significant difference without moving the data. Leaving the data where it is. Let's don't build these huge warehouses. Let's virtualize the data and let digital workers, or that's what we call them at Blue Prism, it's bots, handle the workflows to get the information from point A to point B so that it's very quick, very fast, very efficient. So I was excited. I had been in private practice helping a lot of states and local governments and private practices, doctors and physicians' offices, doing contractual work to help align processes within those organizations. And all for the flow of data and all patient-centric, putting the patient still at the center of what you were doing, because it's a service-oriented business. Healthcare is. But then the ability to move that data and information rapidly so that the patient gets the benefit of that has always been stagnant, I guess you'd say, because it hits so many different roadblocks.
Right.
So whenever I saw RPA, I said, okay, this is the magic potion that will allow us to start to automate, just like the auto industry did. Let's transform healthcare and transform the enterprise in our abilities to do that. So that's how I came here.
Well, and I think for any of us who have been responsible, who've spent some time as a part of the healthcare industry, and certainly now those of us who have spent some of our efforts trying to bring the new realm of automation or newer realms of automation into healthcare, we know that there's certainly some challenges. One of the things that I'm interested in the discussion, and certainly one of the things that I think leads to one of the things that you can do with RPA effectively is your time in health information exchanges. I think most people who are somewhat close to the industry, but everybody knows that healthcare organizations and healthcare technology struggle to talk to one another. The industry term is interoperability.
Mm-hmm.
And I've always believed that one of the things that RPA can do is solve some of those problems. It may not solve all of them, but it certainly can solve some of those interoperability problems. Easy for me to say. So with your background in health information exchanges and now moving into this piece of intelligent automation, where do you see the biggest opportunities, and where do you see the remaining challenges for being able to solve some of these problems up to and until the industry solves them themselves?
Right. Well, I can give you an example of where that one came into play just recently, and that was with the crisis. Of course, we were going through crisis in COVID claims. The physician would, put out an ad, we've got the COVID testing kits available, or we've got the vaccines in, and the patients would go in to get their vaccine or go to get their COVID tests. The physician was anticipating getting paid. Okay, they were a part of a network. They were anticipating getting paid for bringing the kits into their offices. The patients were anticipating that they would get their claims covered, because it was essentially, a task that they had to have in order to be back at work and things like that. But they kept coming back as denied patient responsibility, as well as for the supplies that the physicians were doing. So that in itself screamed interoperability to me, is that somewhere along the path of where that data was going for that claims data, it was either going to the wrong appropriations, or it was hitting a snag in exchange of information between systems. So I knew that it was going to require interoperability, and I was like, okay, so how can a robot or a digital worker be able to have those interoperability standards within them so that they can quickly switch the patient information? And the latest and greatest that I had worked with was a company called Red Hat, and they have interoperability standards. They've been involved with this for quite some time. So what we proposed to a couple of the states was the ability to take those paper claims using OCR, scan those in with the digital workers reading the claims and extrapolating the data, putting them first into a HIPAA compliant format. So as the information came in, the digital worker would transform that to a HIPAA standard, and then we would send it through Red Hat, and they would apply the standards that were associated with interoperability. And then it would come out, it would go directly into the MMIS system at CMS, so that it could be appropriated towards the right claims data. The whole process actually takes less than 2 minutes from start to finish, from the time you scan a document in at the state to the time it is sent in as an electronic claim at that point directly into the MMIS system for either the state if it was a Medicaid claim, or if it went to CMS for a Medicare claim, which is where the appropriations buckets were. Oddly enough, the same whenever we had the dollars that came up, the CARES Act dollars that came up, they were appropriated in a totally different budget system than anything else. They couldn't use them in the state budget. They couldn't use them in the federal budget. So they had to give them an appropriations. And so that's really where the block was hitting, is even though it could have been an electronic claim to be processed, it had to have a different set of ICD-10s, and it had to have a different account appropriation. So once we figured those out, and then being able to apply the standards, we could go from paper to electronic claim and process within, less than 2 minutes. So that in itself shows how quickly we can do that by exchanging information, regardless of the systems of the hospital, into an HIE now. Does that make sense? We don't have to do any of those crazy ETL movements. Just have a digital worker grab it from this Epic system and this Cerner system or this LIM system, all of these different systems that all still have an underlying appropriate language of HL7, some version, and the ability to move those into a FHIR standard and into the systems that they need to without doing those heavy bulk loads of information. So essentially, you got these little people in there doing what a person would do that would take them, so much more time.